Kia ora koutou and welcome to the Beginner's Guide to ACC for Physiotherapists. Now we'll start with our karakia. Whaia, whaia, whaia te tika, whaia te pono, whaia te aroha. Mō te oranga tangata, kia puta ki te whai au, ki te ao marama. Homi e, hui e, tai ki e. Right, welcome. I'm Kate Holmes and I'm an Engagement and Performance Manager with ACC, and I have a background in physiotherapy. So a big part of my role is helping providers understand ACC processes and how to work with us, which is why I'm here with you today, hopefully giving you a few gems on what is involved when partnering with ACC. So I'd now like to hand over to the rest of the team to introduce themselves. So over to you, Chaufu.
Thanks, Kate. Ngā mihi nui kia koutou katoa. Warm greetings to you all. I am Chaufu Wu and I am a clinical advisor with ACC, and I am also a fellow physiotherapist. Over to you, Cody.
Kia ora koutou, I'm Cody Bedford. I'm the health partner managing the physiotherapy sector, so primarily work with Physiotherapy New Zealand and the Physiotherapy Board. I'll hand over to Matt.
Kia ora everyone, my name's Matt Chapman. I'm a portfolio advisor in the allied health space, so I work with physiotherapists, podiatrists and hand therapists primarily.
Great, thanks guys. So Chaufu and myself will present, and Matt and Cody will be moderating the questions alongside a couple of other ACC staff members in the background. So put any questions you have relevant to today's topics in the chat, and we'll answer as many as we can as we go, or at the Q&A session at the end. Now, before we kick into it, I wanted to say a huge thank you for taking time out of your busy clinical days. It's really appreciated, and I hope that you get some good information out of it. So this is a 101 to working with ACC as a physiotherapist. So we will be covering the basics. We don't have time to delve as deep as we'd like, but we will be providing a lot of links to direct you to more information. And just a reminder that this webinar is being recorded to go up on our website, and you'll get the slide deck sent to you with all the relevant links. So don't stress out trying to copy everything down. So we're going to cover these key topics that we know are the building blocks of working with us and will help you to get set up in the right way. So we will be covering about ACC, covering causation, lodging a claim, working with us, working with your clients, roles and responsibilities, digital services, and finally, resources. Now, we know it can be tricky dealing with a huge organisation like ACC, but this should give you a good foundation to build on. Okay, about ACC. So healthcare in New Zealand looks different from other countries, as when someone gets injured as a result of an accident, they come to ACC for support. The rules governing ACC are clearly laid out in legislation, the Accident Compensation Act 2001. It is important to note that it is no fault cover. So no matter what you're doing, even if in hindsight it seems a bit silly, there's no judgment here. And ACC provides the same access to treatment for all New Zealanders and our visitors. So if you're injured as a result of an accident, ACC can help, as long as you meet certain criteria. And then Chaufu, with his infinite knowledge on causation, will provide more information on this criteria shortly. ACC has been around since April 1974, and it's based on the work of Sir Owen Woodhouse. He identified that when Kiwis have accidents, it can have a massive negative impact on their lives if they don't receive the right support. His recommendations for how to address this are the basis of ACC today, as we work to help prevent injuries, provide treatment and rehabilitation, provide financial support to people injured in accidents. Now, to do this, we partner with providers like yourself to help get our clients back to independence and improve their quality of life by minimising the incidence and impact of injury. How are we funded? So ACC is basically a large insurance scheme. We all pay for each other to keep the scheme running. So this is through levies, motorists, workers and businesses. We're also partly government funded for our non-earners and our visitors. So that the scheme is always there to protect us, our whānau, our communities, we need to make sure that we use the system appropriately. Again, you as providers do play an important role in this. Cover and causation. Over to you, Taufu.
Thanks, Kate. Okay, so let's have a look at cover and causation. So what is cover, right? Cover really means, in ACC terms, whether a claim is accepted or not. And it is only once cover is approved for an injury that ACC can consider funding assistance for that injury, such as treatment or other supports. I like to use the example of motor vehicle insurance. Say, like if you have a ding or a fender bender, you call up your insurance company, and then depending on your policy, which in ACC's case is the legislation we're governed by, the claim is then either accepted, say when you have a comprehensive vehicle policy, or not, say if you have like a third-party policy. So basically, in principle, cover for ACC works the same as a private insurer accepting your claim. But the only difference is our no-fault scheme covers everyone. So it includes visitors in New Zealand, as long as they are injured in an accident. The scheme also covers all age group and all employment status. So here's a slide of what we can cover. Excuse me. We can cover physical and mental injuries. For mental injuries, there are three sort of mental injuries that can be sustained. It can be sustained as a result of a physical accident, or it can be a result of a criminal act, such as sexual assault, or from an event in the workplace. We can cover work-related gradual process injuries. We can cover treatment injuries. So these are injuries that's caused by a registered health practitioner during the course of treatment. And this can include a failure of equipment, but not the normal consequences of a treatment. Say, for example, the incision and the scar from having a surgery is not considered a treatment injury. And of course, from October 2022, ACC now covers maternal birth injuries as well. If you're interested to have more detail on what we cover, you can find a list of what we cover on the ACC website. So now that we looked at what we can cover, let's have a look at what we cannot cover. ACC cannot cover injuries that are, or pathologies that are not caused by a qualifying event. Now, typically, this means the conditions that are not caused by a specific accident event, but also injuries or conditions that are not caused by any other qualifying event. What do I mean by that? For example, if, say, you have septic arthrosis from an unknown source, that would typically not be covered. Okay? We don't cover the gradual wear and tear from aging or other degenerative changes. We also don't cover injuries that happens over a extended period or non-definitive period of time, unless they are work-related. Okay, and we'll talk a bit more about this, how this relates to the accident injuries in the upcoming slides. So now that we know what we can and cannot cover, and in the last slide, you remember that I mentioned about qualifying event. So what does that mean? Basically, in simple terms, what is an accident? An accident in the everyday sense is pretty obvious. It's an unexpected incident or an unintended event. But an accident in ACC terms can mean things that are not necessarily unintended or unexpected. Essentially, it just means that an external force to the body or movement of the body to avoid or in response to an external force, and this external force can include gravity, or a twisting movement, like pivoting on a knee. A force internal to the body, rather. Classic example, say biting your tongue, or if you sneeze and cough and you put your back out. These are not considered an accident. Okay? But what's interesting is an accident can include, for ACC purposes, a series of events over a defined period of time. Now, this usually means that it's an unusual activity for that person. So they're doing something that they are unaccustomed to doing and developing an injury as a result of that. So an example may be like normally sedentary person, and they suddenly decide to go on a 3-day hike and then developing a significant blister on their heel. So that could be considered an accidental injury. Basically, if it is to be considered as a series of events, it needs to be an event over a set period of time which caused a one-off physical injury. So a slow and open-ended process does not count as series of events. So those are the more wear and tear and degenerative changes. Okay. So what's a physical injury in the ACC terms? To put it simply, it means that it's a physical or bodily harm or damage. Okay. This can be an inferred damage. So, for example, if you have symptoms of pain, swelling, loss of range of motion, limited weight bearing after an ankle inversion, then that probably is a good indicator that you have an ankle sprain. It can also be a proven damage. Say when you actually go in for an ultrasound or MRI, which actually shows the lateral ligament injury of the ankle. But it's important to note that symptoms themselves are not physical injuries for ACC purposes. So in other words, if your patient comes to you, in the clinic and they present with pain or weakness or swelling, there may be physical injuries causing these symptoms that could be coverable, but these symptoms themselves cannot be covered. So you can't be covered for, weakness in the back or back pain, simple back pain. So we really want to encourage you to think about the condition that you're treating in front of you and whether it truly represents an actual damage. So, and also taking into consideration as well the natural healing timeframes of physical injuries. So general rule of thumb, physical injury, soft tissue, non-complex injuries caused by a one-off accident event usually will heal alongside sort of normal tissue healing timeframes. So we're talking about weeks instead of months or years. Here's an example to think about. Say a patient with a long history of recurrent episode of non-specific low back pain. And then something happened, which coincided with an episode of the back pain. So a claim is lodged for lumbar sprain. How long do you think ACC should provide treatment and support for that back pain? When you come across similar scenarios like this, you got to remember that treatment and support can only be provided by ACC for symptoms as long as they themselves are caused by physical injury that's covered. Okay, and on this slide, there's a hyperlink to the ACC website if you want to know more details about this cover. And here's a slide with a picture of what the quick guide on causation looks like. So now that we know about accident and we know about injury in the ACC context, why does it matter? Okay, you can find a copy of this quick guide, and there's actually also a separate video about causation on our website. So again, strongly encourage you all to check it out. Now, normally when you're seeing your patient in the clinic, right, you take history, you get the onset of the symptoms, you get a description of what happened. That usually gives you a reasonable clue as to whether the event that they are describing caused the injury that you're seeing in front of you, right? Of course, sometimes it won't make sense. And, it could be a random onset of symptoms where the patient either tells you that maybe they woke up with a pain, or there's actually no particular event at all they can recollect. When that happens, it's pretty safe to say that it's unlikely that the injury, that the presenting complaint that you see in front of you is caused by an accident. Right? But of course, sometimes a patient will recall something that happened, okay? But it simply won't fit in with what you're seeing in front of you clinically. Say if the patient is presenting with Achilles tendinopathy, but then say, oh, I had an ankle sprain stepping off the curb last week. It's pretty safe to say that a single event of, possible sprain is unlikely to cause a chronic condition like Achilles tendinopathy. Now, the important thing to remember, though, is the series of events that we mentioned before. If you're treating for a series of events claim, the identified physical injury needs to be consistent with that series of events. So if we're using the same Achilles tendinopathy example, okay, you got to think about things like, okay, is this really from the 3-day hike that the patient say they did yesterday? Or is it actually a chronic tendon change, from their training for, say, half marathon that they do every year? Factors like this is important to keep in your mind for consideration. And that is also why it's very important to remember that symptoms alone are not physical injuries for ACC purposes, because there may be a continuation of symptoms, and the symptoms may, be the same pain, same inability to walk properly. Symptoms may manifest the same, but it may not be the covered injury. And that's why we rely on your clinical reasoning through your assessment findings to show what the diagnosed physical injury is. In other words, what you are treating. Okay. And next slide. Thanks, Kate. Okay. So I know all this information sounds a bit overwhelming at first, but essentially, to understand the concept of causation, these are the questions that you need to answer. Okay. To put it very simply, when did it happen? What were you doing? What went wrong? And what did you hurt? Now, the date of accident is important because, if a claim if it's a soft tissue injury, especially, and that happened 12 months ago, think about why hasn't it got better, right? Normal healing. Why hasn't it kicked in? And also for ACC purposes, when a claim is launched a year beyond the accident date, it will actually be put on hold while ACC requests the clinical information to do a bit more assessment on it, because it's considered a late lodgement. If the initial presentation, say, for example, is like a bleeding laceration on the right calf from the patient scraping it on the dishwasher door. And then the next session they come in and the symptoms becomes, pain in right hip. And that, that's when you got to start to think about, okay, how is this related to the claim that they have for the right calf laceration? Okay, is it related at all? Is it even related to scraping their leg against the dishwasher door? And it's the same principle applies if you are treating them for a work-related gradual process injury. Okay, for example, if a carpenter has a work-related gradual process injury cover for a medial epicondylitis, then you got to think about, okay, is there any non-work factors, maybe sports or family commitments that might be contributing to the ongoing symptoms? Why isn't it getting better despite the patient may be off work, for example? Okay. So now that I put all these ideas in your head, let's have a look at a few quick examples. Okay. So in this example, Gary was running on a bush track on a peaceful Sunday morning. He tripped and he fell and he dislocated his left shoulder. Okay. Looking at Gary's situation here is pretty straightforward, right? we have an accident, a fall, and onto, presumably, the ground. That would be a force of gravity, of course, combined with Gary's momentum when he's running and the impact on the ground. We have an injury, which is a shoulder dislocation, which we normally expect it would involve some soft tissue damage. So we have a causation, clinically makes sense. There's a sudden, excessive, and unexpected force through Gary's arm, causing a dislocation. Nice and simple. Okay. But we know that, of course, in a clinical setting, not everything is that clear cut. So let's have a look at this second example. Ruth presents with an 8-week history of shoulder pain and stiffness after pulling out a stubborn weed. Now, you will see that in comparison, this is a relatively minor event to what Gary was experiencing. So, but it shows you also that even a minor event like this, pulling out a stubborn weed, can still be considered to be an accident in the ACC context, because it could still amount to an external force, like the resistance of the weed, the sudden and unexpected release. That's an external force. But when you're presented with a scenario like this, you got to think about, okay, what is the injury here? All right. Ruth has pain and stiffness in the shoulder, but remember, these are symptoms and they don't equate to a physical injury. Okay. So you go, oh, okay, do a bit more closer assessment, more questioning, and then you find out, say, Ruth was getting worse over the last 8 weeks instead of getting better. And then you did your assessment and you found that Ruth has a medical history of diabetes and is actually presenting with a frozen shoulder. And that is not actually caused by pulling out the weed. But instead, it was rather because of pulling out the weed, she first noticed these symptoms of pain and stiffness. So in this situation, then, there is an accident, which is pulling out the weed. Okay. There is a physical injury, which is the frozen shoulder, but there's no causal link between the two. Okay. So it is important to remember that it is not uncommon in a clinical setting that patient would recollect an event and then attribute their symptoms to it. Okay. So I hope I haven't lost you so far. And if you think that that was complex, here's another one. Bob has just returned from a 3-day hiking trip, and he remembers stepping off a curb funny and felt a twinge in his right ankle about a week ago. He now has a right calf and ankle pain. Okay. So again, think about what is the accident event here. Okay. There's 2 potential possibilities. Right. Is it stepping off the curb a week ago, which would be a single event? Or is it from the hiking trip he just came back from? A 3-day hiking trip, which could be a series of events. Okay. But more importantly, what physical injury did he sustain? Okay. So say on assessment, you found that Bob is presenting with right Achilles tendinopathy. And then you found that, Bob is a very active person. He's a very keen marathon runner, which he trains for regularly. So you need to think about, okay, what is the more likely correlation of these factors? What is the clinical picture that you've seen in front of you? And are there other factors? Say, for example, does Bob have any underlying biomechanical issues of his lower kinetic chain that is contributing to his current symptoms? Okay. So what we're trying to encourage you to think about is, think about, was there an ankle sprain injury in this example? Did it cause that Achilles tendinopathy? Or is this a simple case that the Achilles tendinopathy was irritated into presenting acute symptoms from all these factors and these events? So in order to prove causation, or as we commonly say, causal link between the injury and the event, again, ACC relies on your clinical reasoning that you will need to demonstrate in your clinical records. So let's have a look at lodging claims.
Thanks, Chao-Fu. There's a lot to think about there. Right, lodging claims. So all claims begin with the ACC 45 form. Now, this is the basis of your cover, of the client's cover with ACC. So the ACC 45 form is important to help us decide if an injury will be covered, and if so, under which category. Making sure that the information is correct before lodging will mean faster access to treatment and support for your client. So please make sure that the diagnosis is within your scope of practice, the patient's details are completed and correct, there is an identifiable accident and injury, and just be aware that the treatment injury box is only ticked if the injury was caused by a health provider while providing treatment. On the ACC 45 lodgement form, you need to use a diagnosis read code that best represents that injury. As Chao-Fu mentioned, the diagnosis needs to be a physical injury, so not a symptom, and it needs to be consistent with the accident event. Sometimes there may be a clinical suspicion of an injury, but it's not yet proven on imaging, such as an ACL tear. In cases like that, use the sprain read code that matches that injury until imaging confirms otherwise. So in this case, you'd use the S542 sprain of cruciate ligament of knee. The injury read code can always be updated to be more specific after lodging using the ACC 32 form, which we'll talk about soon. Always remember that you need to be satisfied that the accident caused an injury. So you may not know exactly what that injury is, but the mechanism and the clinical picture still needs to have that causal relationship. Over to you, Chao-Fu.
Okay, thanks, Kate. Okay, so why is it so important that you get the cover right? Firstly, having the right diagnosis means that we can pay you for the treatment that you provide. Very important, right? It is also very important that we cover the right injuries so that we can make good decisions about treatment. For example, most claims would likely be lodged with, say, a sprain diagnosis, but then might show that there is more severe damage. So we need to know that, because that may mean that the clients need longer to recover, or maybe they need more help than first expected, because the diagnosis of the sprain is no longer an accurate reflection of what had happened. Alternatively, in the course of your treatment and investigation, you may find that the client's condition is no longer ACC related. So you need to make sure that you're no longer treating it under the ACC claim. Okay. So an example may be if you're treating a knee sprain and the person with advanced knee osteoarthritis, and at some point, the problem becomes the osteoarthritic changes. Even though the symptoms may still be the same, like the pain, the swelling, the inflammatory response, the stiffness, the range of motion loss. Because you got to remember, again, thinking back to causation, and thinking back that just because an event coincides with the activation of symptoms in time, that is not a causal link. Okay. Or say another example, maybe if you are treating rotator cuff sprain, and then you discover that in fact, oh, it's actually an idiopathic frozen shoulder. It's, say the patient was just using a hair dryer, blowing dry the hair, and go, oh, ouch, and initially thought it was a rotator cuff sprain, but it's actually a frozen shoulder. So making sure that there is the right cover would also help you figure out if there is a causal link.
Thanks, Chao-Fu. So how to work with us? To work with us, you'll need a provider ID. So to get this, you'll fill out the ACC 24 form and include your annual practicing certificate. Our registrations team will then work with you to verify your email, and this doesn't take long. You'll usually have an ID number within 1 or 2 days if we've got all the information that we need. Your employer may support you in doing this, which is awesome, but just make sure that you are aware of and read all the relevant onboarding resources on our website. There are 2 main ways a physio can work with ACC. So firstly is the cost of treatment regulations, or you may have heard some providers previously referring to this as med fees. This is for services provided under our legislation, and so the government has a large part to play in pricing these services. Under regs, you opt to either charge us per hour or per consult. The per hour is calculated at 5-minute intervals, and there's a module on this online. Prior approval via the ACC 32 process is required after 16 treatments, and prior approval is also needed for any equipment, such as braces. There's a link there at the bottom of the slide to take you to the pricing that we contribute towards your treatments. Now, the other way to provide your services is through the Allied Health contract. This is an ACC contract which allows us to set our own prices based on what we believe are the market rates. And we work with the professional bodies to understand what's happening in the sector. Under this contract, you'll be paid a flat fee for initial and follow-up consultations. Prior approval is not needed after the 16th treatment. However, a clinical review does need to be done prior to this point by your clinical director if there's been no specialist oversight. To access the higher rates on the contract, you are required to have a clinical director, for your clinic to be accredited, and for all providers to be members of your professional body. For more information on the contract, please read the service schedule and the operational guidelines on our website. This will give you a wealth of information on how to work with us, codes you need, telehealth, maternal birth injuries, equipment we provide, and so on. So as you've seen, one of the key differences between working under regulations and under contract is the fact that under the contract you need to have a clinical director and accreditation. The clinical director for your clinic is a senior clinician with at least 5 years experience and a postgraduate certificate in the scope of practice relevant to your clinic. Their role is inducting new staff, in-service trainings, clinical oversight, ensuring the quality and safety of treatments, ensuring treatments are appropriate and progressing, and understanding and compliance with the contract. The clinical director also performs the clinical reviews. This role can be subcontracted when needed with agreement from ACC. Now, regarding the accreditation, you can choose which one of those 2 standards you want to be certified against, and the practice must be certified by a conformity assessment body. The current accreditation bodies are stated on our operational guidelines for you to make contact with. I don't want to inundate you here, but there are a lot of other contracts using multidisciplinary teams that physiotherapists can work under. And we've named a few of the larger ones here: VOC rehab, training for independence, concussion, pain, and assessment services. Information on all of these is on our website. And to find them quickly, I usually just type the service, for example, concussion, into the search bar at the top right of our website. And the links to the service schedule and op guidelines will generally show up on that first page. Also, if you think your client needs to access some of our contracts, you can contact ACC to seek prior approval and kickstart another service if needed. Right, working with your clients.
Okay, so what do ACC expect when you're working with our clients? In addition to the covered injury and the causal link that we talked about before in Chapter 2, when you're treating patients under ACC claims, you also need to think about necessary and appropriate. Now, this is the actual term used in the legislation. So again, necessary and appropriate. The more common example that we see are either over-servicing or under-servicing. So, for example, if the patient is better after 10 treatments, and you get them to come back 6 more times because the trigger number is 16 treatments, and you have 3 slots in your calendar, for example. Or if the patient is actually not better after 30 treatments, and you've not considered any onward referral or further investigations, say like getting a specialist opinion. So when you're treating your patients under ACC, we encourage you to think about, okay, what other supports do they need and who else can help? For example, do they need an opinion from, say, an occupational therapist, or maybe an input from a podiatrist, or maybe just as simple as, getting some transport help to get to your clinic for the treatment of their broken hip because they can't drive anymore. It's because ACC can provide a variety of help for covered injuries. So if it is appropriate to do so, think beyond just simply continuing treatments, physiotherapy treatment within your clinic.
Treatment extensions and updating a diagnosis. So this is where the ACC 32 form comes into play. You'll need to get in touch with ACC when you have or you're about to reach the treatment trigger of 16 if you're under regs or 50 if you're under contract. It's been over a year since your patient was treated by an allied health provider for the first time. You're adding or changing a diagnosis, or you're requesting equipment. There are 2 ways of getting these extensions or changing the diagnosis. If it's a standard request, you can just call us. If it's a complex request, you'll need to fill out an ACC 32. So let's look at the difference between the 2. A request is considered standard when the injury is already covered, it's within 12 months of injury or surgery, it's the first request from your clinic, and it's for the original diagnosis. A request is considered complex when it's over 12 months since first treatment or surgery date. It's not your first request. If you're contracted, you've reached 50 treatments, or if the diagnosis has changed. For complex, you'll need to supply your clinical information as well. We will consider each request on a case-by-case basis, and we'll let you know if we've accepted it or declined it. Now, there's a lot of information here, and it can be confusing, but use the link to go to our website for more information on which way to submit, and you'll also find a list of the read codes there too. Right, roles and responsibilities. Once a year, we'll send you a document that looks like this. This is your ACC provider dashboard, and it's a summary of the data that we've collected about you individually, and it shows how you compare to other physios working with ACC. Some of that statistical data can be really helpful for your self-reflection and your CPD. For example, the common injury types you see and the ages of your clientele. Our responsibilities. So as mentioned in previous slides, ACC is bound by legislation. This legislation, it outlines what we can and cannot do to ensure that we're providing a sustainable scheme for injured New Zealanders. So our role as good stewards is to ensure that we're guardians of the scheme, meaning we will ensure our clients get the support they need. We will provide support to you to help you understand our legislation, policies and procedures. We will give and receive feedback. So here we're talking about a reciprocal, 2-way conversation about ensuring our clients get the support that they need. And we'll pay you promptly for all necessary and appropriate services. Now, when we are providing funding to you to deliver treatment services under the scheme, we expect you to comply with the ACC Act, our policies and procedures, to provide our clients with services that are goal-orientated, evidence-based and clinically justified, that you comply with your professional standards and ethics, that you'll protect your client's privacy, that you'll follow our position statements, which are on our website, and that you'll be culturally safe. Our Working Together handbook is a great resource, so check it out on our website.
Okay, so let's talk about clinical records. Of course, having a good quality clinical record is part of every physio's job, and the Physiotherapy Board has a clear standard and guidelines on what they expect to see in good quality clinical notes. But it is important to know that ACC has some additional things that we need to see from you, which we've included in this slide. Some of them are pretty sensible and obvious, like having a claim number and an injury diagnosis. But everything else on the list is just as important because they help to show things like causation. So remember that link between the accident and the physical injury and the treatment that you're now providing. So in the clinical records is also, of course, important to show the good work that you're doing with a patient. So it's important to have not only a treatment plan, but also show the progress of your treatment plan. And also it's a good place to demonstrate how you're measuring these progress and whether you've achieved any improvement in patient's function each session to allow you to assess whether you want to continue or make adjustments or any other recommendations as the treatment is going along. This is to ensure that you are always delivering a treatment that is necessary and appropriate and the very best for the patient. Of course, this is just a very brief and quick overview on clinical records. We do have another webinar on clinical records. And again, I'd encourage you all to go onto our ACC website and check it out.
Cultural safety. So in April this year, we launched our ACC cultural safety policy called Kaura Whakaruruhau. It was designed in collaboration with the sector, and it weaves together te ao Māori and non-Māori worldviews, knowledges and practices. It sets out our expectation on cultural safety across all of our funded services. This supports providers and suppliers in delivering culturally safe care to our kiritaki, our clients, and whānau. So it's important to recognise the difference between cultural competence and cultural safety and how they are both important to a kiritaki. So cultural competence focuses on the culture of the kiritaki and ensuring that you have the attitude, skills and knowledge to function effectively and respectfully when treating people of different cultural backgrounds. And then cultural safety is about you as the practitioner and the organisations that you work with to examine yourself and the potential impact of your own culture on clinical interactions and service delivery. Our Te Whānau Māori Mio Mahi guidance on cultural competence is designed to sit alongside the cultural safety policy. So while the policy is the what, this guiding document is a resource to support the how. You can find these and additional resources, including FAQs, on the link on the slide. Digital services. So once you've signed up, there are two ways to connect with us, either via your PMS or your practice management system, or by using our online services. So PMS can work directly with us for lodging claims, finding claim or invoice information, submitting invoices, and getting remittance advice. If you don't have a PMS or it doesn't offer all our services, you can contact our e-business team to start using our online services. As always, head to our website for more information. But as a side note, ACC lets providers and PMS vendors know of any pricing or code changes. So it's really important to read your correspondence from us and do let us know if your email changes. Our monthly provider updates are also packed with great current information So be sure to read those too. Getting paid, this is important. So when you submit invoices, electronic is best. So you can use the practice management system or our online services, as I mentioned. So electronic billing is quicker and it's safer, privacy-wise, and it's prioritised for processing over manual billing. So when you've lodged a new claim, please send the electronic invoice after the claim is registered with a claim number. And you should be invoicing within 2 months of providing your treatment. Resources. Now, there's a lot of stuff to cover, and we've only gone over the basics today, but there's a lot more brilliant information available for you to use on our website. This includes educational resources and modules tailored to profession. We're always creating new resources too, so if there's anything you particularly want to learn more about, please do just let us know. Okay, so we've completed the bulk of the presentation, and so now we've got some time for final questions. Cody and Matt, have there been a few come through?
Thanks, Kate. Yes, I will just pull some up. So I have one for you here, Kate. What to organise with ACC if you ever want to start your own practice?
Okay, so to start your own practice, you'll have a provider ID, which we talked about, but you'll also need a vendor ID. So for this, there's a form, you'll see it on our website, it's the ACC 111 form. And then on top of that, if you're wanting to hold the contract, what you'll need to do is go onto the GETS website, which is Government Electronic Tenders Services. And if you just search for Allied Health, it'll come up, it'll show you how to apply to hold that contract. There'll be questions for you to answer, and as well those requirements that you need to meet that we spoke about. And yeah, otherwise, the rest of the information about how to work digitally with us as a vendor, that's all on our website too.
Thanks, Kate.
Ciao, a question for you. Can you please provide clarification around when the ACC would like a new claim done? It seems such a grey area for doing a new claim versus an aggravation of an old injury that's settled, then re-stirred up again.
Thanks, Matt. Yeah, that is a very good question, and it is a very broad question, so I'm going to try and narrow it down as simply as I can. To put it simply, it really depends on the clinical context. If you think about back to the chapter 2 when we were talking about cover and causation, it's really dependent on the context of what had happened. That enables you to decide whether you are lodging a new claim or whether it is an aggravation of, say, a prior or an older injury. I think most important to keep in mind is that cover is very accident event based. So each new accident, as long as it's caused a new physical injury, then it requires a new claim. So that's sort of the first sort of simple rule of thumb. If it happens to overlap with previous claims, or say if there are symptoms so that's still unresolved from previous claims, then I guess it's a common sense approach, and it does rely on your discretion as a clinician to decide, okay, this back pain that I'm seeing in front of me, is it from the lumbar sprain that he had from 6 months ago? Is it from this patient bending down to pick up a piece of paper yesterday? Or is this since I've been treating him for the last 6 months or so, is this the postural or the underlying sort of lumbar instability and the core muscle weakness that we know that it's underlying, or even, is it the underlying sort of lumbar disc genic changes that we know that this 40, 50, 60-year-old patient has in the background. So it really depends on a lot of variable you do have to consider, and we do rely on you as a clinician to gatekeep for us to decide, okay, what is the best approach? Do I lodge a new claim, or do I see this as a continuation of the previous claim? And whatever your decision is, as long as you can demonstrate that clearly in your clinical records, so that if ACC needs to, we request it and we assess it, and it makes clinical sense, then it's all okay.
Thank you, Chow.
Awesome. Great answer, Chow. Kate, I have one for you. How much support from their employers should new graduates expect to receive? What if there is no support offered?
Okay, so as you said, we don't stipulate to businesses what support to give. However, a good employer will always invest time in developing their staff, especially new grads. I mean, if you think about that first year out of uni, it's just exponential growth with regards to your knowledge and your confidence. So that's definitely a great question that you should be asking when you are discussing or negotiating your job. Personally, I would be asking for regular and structured clinical supervision, as well as some of those other points we talked about that some of the clinical directors do, like your in-service trainings and things. There is stuff to do yourself online, like our modules, but I think on the ground, actual practical, like I was saying, supervision, that's something I would suggest that you're talking to your employer about before accepting a job. As I said, they'd be doing well to be investing in your development. So that's what I'd be looking for. You want to get your career on the right path. Yeah.
Thanks, Kate.
Yeah, one more question for you. What if you are treating patients with multiple ACC injuries and treating across injuries during a session? How should this be documented?
Usually in a clinical setting, inevitably you will tend to focus more on the more serious injury as compared to the minor injuries. And it also, another relevant factor to consider is how your billing practice which billing practice you chose. You remember Kate spoke about, whether it's the cost of treatment regulation or whether it's contract, and whether it's per hour or per session. Of course, there's a separate module that, again, we encourage you to have a look on our website on. But when you're documenting it down, I guess it is, again, it's a priority as a clinician. Okay, what is the majority that you are spending your focus on? And the general rule of thumb would be to, invoice under that claim. Because realistically, the more that you're trying to address in one session, which we all know is a limited time, each session, the more that you're trying to spread out across each session, the more you're trying to spread thin, and you're not sort of giving each of the injury perhaps the attention that it needs. So we do encourage you to try and keep things simple for yourself and focus on the more severe side of things. So you can think about that, say, for example, if the patient comes in with both a lumbar claim and an ankle sprain claim, you can alternate your treatments. Like if you're addressing the lumbar as more sore, waking up today, giving the patient more grief, focus more on lumbar today, and say you address the ankle sprain injury tomorrow, perhaps, or in a couple of days time when the lumbar symptom has settled because of the treatment that you provided today. And then in that case, then you will be able to document, okay, today I treated the lumbar claim, 2 days time, or tomorrow I treated the ankles claim, etc. So and you can bill accordingly. So prioritize and keep things simple for yourself.
Thank you, Chow.
Thanks, Chow. Kate, just one last one there for you. I'm interested in knowing more about what extra support ACC covers and how to access it for clients. This can range from orthotics appliances, support with travel to and from appointments, continuation of income when injury interrupts work, Any thoughts there?
Yep. So for the continuity of income, so we call that weekly compensation, and that's something that your client will be talking to ACC about. So we don't cover that first 7 days, but after that, if it's all accepted, it is 80% of the wage. But as I said, that's something that the client will be talking to ACC about. Same with the transport. If they need transport to and from appointments and they've got no supports to help with that, then they can talk to ACC about how we can help. What's the other one? Orthotics and appliances.
Yes.
Yep. So that depends. So under the contract, we've got codes for knee braces, for moon boots and crutches. If you're under regs and you think some equipment should be funded, you can apply for it under the ACC 32 form. Just be aware that you should be setting that expectation with the client that, we can apply for this, but if it's not accepted, it is something that will be paying for privately. And those smaller, like off-the-shelf orthotics or heel raisers, TheraBands, that type of stuff, we would expect the client to fund privately for those. And then, of course, you can always refer to a podiatrist if needed. Did I miss anything there?
No, absolutely perfect. Thanks, Kate.
Okay.
Just checking in with the team. Is there any other questions? I don't see any others here, so we might close that off. Perfect. Cool. Back to you, Kate and Xiao.
Oh, thank you. Okay, so we are here to help. Please get in touch with us, and here are a few helpful contact details for you. I'm not going to linger on the slide as you will get them in the slide in the deck. What's next? So please just take a minute after this webinar to let us know your thoughts. We are particularly interested in what you thought about the format of this webinar, what you liked about it, and how it could be improved for the future. Please also let us know if there are other topics you'd be interested in hearing more about. Just simply click on the link in the Q&A and share your feedback with us. Again, a huge thank you for giving us your time today. We do really appreciate it. And we'll now finish with the karakia. Whaia, whaia, whaia te tika, whaia te pono, whaia te aroha, mō te oranga tangata, kia puta ki te whai au, ki te ao marama, homi e, hui e, taiki e. Okay, thank you.
Thanks, everyone.